Welcome. In this lecture, we'll be discussing different types of acute flaccid paralysis. Let's first go over some definitions. Acute inflammatory demyelinating polyneuropathy, also known as AIDP, is going to be a type of acute, rapid onset flaccid paralysis. The most common form of AIDP is going to be something known as GBS, aka Guillain-Barré Syndrome. Chronic inflammatory demyelinating polyneuropathy is typically going to be slow and progressive flaccid paralysis, which is typically going to be longer than 8 weeks until it reaches its plateau. Thus, the main difference between AIDP and CIDP is going to be time. AIDP is going to be rapid in onset, less than 4 weeks in order to reach its plateau of symptoms. CIDP is going to be greater than 8 weeks in order to reach its plateau of symptoms. Let's discuss mostly AIDPs throughout this lecture, with the first one being Guillain-Barré Syndrome, the most common form of AIDP. The pathophysiology of Guillain-Barré Syndrome involves an acute immune-mediated attack on the peripheral nervous system. This leads to demyelination and/or axonal damage. This is done by something known as molecular mimicry, which does exactly what it sounds like. The immune system generates these autoantibodies against a pathogen, and this cross-reacts with different types of gangliosides. The autoantibodies in this case can attack either the myelin sheath or sometimes axons. Remember, Guillain-Barré syndrome affects the PNS, or the peripheral nervous system. In particular, it affects something known as Schwann cells. If you remember back to your neuroanatomy days, Schwann cells are a type of glial cells in the PNS that form the myelin sheath around nerve fibers. This allows to speed up electrical signal conduction. It does other things as well, such as support amyelinated axons, clean up debris, and other things. But the big takeaway from this slide with the pathology of Guillain-Barré syndrome is that GBS affects the peripheral nervous system, aka Schwann cells, by a process known as molecular mimicry. This creates these autoantibodies which attacks these gangliosides. Now, usually Guillain-Barré syndrome is preceded by some sort of infection. We see this in roughly 60 to 70% of cases. The most common cause of Guillain-Barré syndrome is going to be associated with Campylobacter. So look for nausea, vomiting, or diarrhea within the past few weeks on exam day. Now, there are other bugs that are associated with Guillain-Barré syndrome, as well as viruses, such as CMV, EBV, aka mono, Epstein-Barr virus, mycoplasma pneumonia, or Zika. But definitely understand that Campylobacter is going to be the number one cause of Guillain-Barré syndrome, or the number one associated cause. Now, here is a quick diagram demonstrating GBS. As we can see, here is our infection, our Campylobacter, and this initiates some sort of immune response. This produces autoantibodies, or antibody production. This leads to, in this case, ganglioside mimicry, aka molecular mimicry, in which the molecule that we are mimicking is going to be a type of ganglioside. This affects the peripheral nervous system, aka Schwann cells, which typically leads to demyelination. Now, what exactly do we see in the symptoms of Guillain-Barré syndrome? Well, typically we'll have some sort of history of GI or GU tract infection. This typically is going to be within the past few weeks. Typically, GPS is going to take a few weeks in order to develop. It should not be with an undergoing or current GI/GU infection. We'll typically also see a very classic presentation with GBS, where we will get symmetrical, bilateral, ascending muscle weakness. In GBS, the distal limbs are affected first, because their long nerves are the most vulnerable to immune-mediated demyelination. This leads to the early symptoms like tingling, numbness, weakness, typically of your hands and feet. You'll get something known as a stocking glove presentation. This is also associated with diabetic or polyneuropathy. Thus, we will see in Guillain-Barré syndrome, you'll typically also see the feet or the hands or the distal aspects will be affected first. Then it will ascend these limbs. That is very important to understand. It is not that it just affects the lower extremities. It will affect the more distal areas first and then ascend from there. You will also get absent reflexes. Remember, we are affecting those peripheral nerves. If you remember back to your spinal reflexes, that is due to a lower motor neuron or a peripheral nerve. Thus, if these are demyelinated or damaged, you will lose or have diminished reflexes. You will also see those sensory changes, such as those numbness and tingling. Understand that with Guillain-Barré syndrome, we typically can see all three: loss of reflexes, motor weakness issues, as well as sensory changes. Definitely will typically see the motor changes as well as the absent reflexes. Understand that for test day. Now, the diagnosis is typically clinical, but it is important to know what we may see in some images or studies, as this will typically either be given to you in a test question or sometimes be asked for you to interpret. One of this will be your lumbar puncture, which you'll see albuminocytologic dissociate, fancy way of saying elevated protein in LP. The reason being is because the inflammation and the immune-mediated nerve root damage make that blood nerve barrier leaky, allowing the protein to enter into the CSF. You may also remember this by a mnemonic, AIDP. Remember, Guillain-Barré syndrome is the most common form of AIDP, where the A stands for that ascending paralysis that we typically see. So from the feet and the hands upwards is typically immune-mediated, leading to demyelination or destruction of the peripheral nervous system. And you typically see protein in the CSF. Now, there are a few other studies that can be done, such as EMG or MRI. EMG is not very helpful, as we will typically see just slowing of the conduction or diminished amplitude, and most of the time, MRI is normal. You may see some form of enhancement, but for test purposes, you expect your MRIs to be normal. Thus, the one I would definitely know for test day would be your LP results or LP findings. Now, there are some severe symptoms that you definitely want to know for Guillain-Barré syndrome. The first one is going to be respiratory failure, which is typically due to the immune-mediated paralysis of the muscles involved in breathing, or your respiratory muscles, especially the diaphragm and the intercostals. This is a very, very severe symptom seen sometimes in GBS and sometimes require elective intubation or mechanical ventilation. Thus, it is important for people with GBS to undergo spirometry at least a few times in order to get a baseline, especially in their forced vital capacity, or FVC. Remember, FVC is going to be when you take one full breath in and one full breath out. That is your forced vital capacity. How much air can I move through my lungs? This is the most important spirometry measurement. So understand that FVC and spirometry needs to be done in individuals with Guillain-Barré syndrome is very important, but so is when do we intubate. Now, there's a multitude of different indications to intubate, but I'm going to try to simplify this as much as possible. Remember, FVC is our most important measurement, so this is going to also help depict when we need to intubate. Typically, if we see a decline in FVC less than 20 or greater than 20 milliliters per kilogram, that would be an indication for elective intubation with or without respiratory issues. Other indications can be that severe respiratory distress. If an individual looks like they're gasping for air, having trouble swallowing, breathing, something along those lines, then that would also be an indication to protect the airway. Widened pulse pressure or other autonomic dysfunctions can also be indications. This is typically due to some sort of abnormal control of vascular tone and blood pressure, and it reflects the unstable autonomic regulation, and typically people with Guillain-Barré require careful cardiac and hemodynamic monitoring. Now, there is a mnemonic to help you remember the indications for Guillain-Barré syndrome intubation: A, B, C, D, E, F, G. I won't go through all of them, but understand that each of these, such as gag reflex, failing vital capacity, count to 10 test fail, airway protection, all of these are screaming the exact same thing. They're all signs of respiratory distress. Thus, people with lack of mobility, lack of the ability to use the muscles around our respiratory system is going to be an indication for intubation with Guillain-Barré syndrome. But I would argue if you just know these two here, you should be able to know on test day whether this patient needs to be intubated or not. The other thing that we have to watch out for is arrhythmias. These individuals, as we already talked about, will require cardiac monitoring, specifically bradyarrhythmias, As remember, we're destroying peripheral nerves, so everything's going to be slowing down or decreasing due to the demyelination. This will typically follow your typical ACLS guidelines. If they're hemodynamically stable, we can give them intravenous atropine. Some individuals may require fluids. And of course, you can also do transcutaneous pacing if they are hemodynamically unstable. But definitely understand this slide for test day. Now, with Guillain-Barré syndrome, it's typically a progressive disease and has 3 main phases. Those phases are going to be your progressive phase, which is typically 2 weeks. Remember, it's a form of AIDP, which is going to be less than 4 weeks in order to reach its plateau phase. In this case, the plateau phase will last around 2 to 4 weeks, and the recovery phase will be several months. GBS helps to remind me that Guillain-Barré syndrome gets better slowly. A lot of individuals with GBS will get better, but it will take many, many months in order to get back to their baseline. Why exactly am I highlighting these phases? Well, it's important because treatment has been shown to shorten the time to recovery. This is typically done by shortening the plateau time. What do I mean by this? If an individual with GBS typically has 2 to 4 weeks of plateau time without treatment, then receiving treatment may lower that number to 1 to 2 weeks, putting them into that recovery phase even quicker. That is how the treatment modalities work. Now, what exactly are these treatment modalities? Well, you have IVIG, or intravenous immunoglobulins, and of course plasmapheresis. Intravenous immunoglobulins and plasmapheresis are equivocal. IVIG is just as effective as plasma exchange, which has been seen in a multitude of different studies. But typically in the clinical setting, IVIG is going to be preferred due to the ease of use and the safety. Plasmapheresis, aka plasma exchange, removes the antibodies from the blood. This is typically more invasive and requires central access. Thus, for test purposes, they are equivocal, but in the real clinical practice, you'll probably see IVIG used more. I want to include that just in case they do make you choose between this on test day. Understand that IVIG is typically much, much easier and simpler to use. The rest of the treatment is typically supportive. PT, physical therapy, rehabilitation. Some individuals require DVT prophylaxis if they are unable to fully move. And of course, that respiratory and cardiac monitoring that we've talked about. Now, there is a subset of GBS known as Miller-Fisher syndrome. This has a classic triad. That triad is going to be ophthalmoplegia, which is typically paralysis of eye muscles, ataxia or poor coordination, and of course, areflexia. Remember, Miller-Fisher syndrome is a subset of GBS. GBS, we destroy or affect the peripheral nervous system. Thus, individuals with GBS are always going to have areflexia or some sort of diminished reflexes due to that. Now, it is also important to know that Miller-Fisher syndrome is highly associated with anti-GQ1B antibodies. These are autoantibodies that target GQ1B ganglioside. This is a type of glycolipid found abundantly in the cranial nerves, particularly in the eye movement nerves. So unlike GBS, Miller-Fisher syndrome typically affects cranial nerves instead of those distal nerves that we see in the hands and the feet. So definitely understand this and look for this triad on test day. Miller-Fisher syndrome is treated exactly like GBS because it is a subset of GBS. Now, what is GBS typically compared to? There are other types of acute flaccid paralysis. One of this is going to be something known as botulism. Now, there are a multitude of different types of botulism, but the main ones that you need to know is going to be infant and, of course, adult. Now, the pathology here is going to be very similar, but there are some caveats that I want to stress. With infants with botulism, this is typically due to the ingestion of the spores from environmental dust. Typically, you want to see an infant on test day who has either been given honey or may have been playing in soil. The big thing to emphasize here is that the spores are going to be the ones that are entering typically the GI tract. Where with the adults, you'll also have ingestion again, but this will be of some preformed botulism toxin. Individuals are typically exposed with this with improperly canned foods and, of course, sometimes aged seafood. So here's a diagram quickly describing what's happened. Typically what happens here is we have some sort of toxin entry. Here we can see step 1. We have the botulism toxin binds to this presynaptic cholinergic nerve terminals. This undergoes something known as endocytosis, where the toxin is going to be internalized into this neuron. The most important part is here, step 3, this snare cleavage. Your snare proteins, which are essential for the function of your synaptic vesicles, allows for acetylcholine to release at the neuromuscular junction. Typically in botulism, though, the botulism toxin cleaves these snare proteins, which disrupts these vesicle fusions, blocks that acetylcholine release. This does not allow that acetylcholine to release into your neuromuscular junction, which does not allow for muscle movement. This leads to flaccid paralysis. So what's the big takeaway here? The big takeaway here is that the botulism toxin, no matter which way it enters, eventually is going to cleave these snare proteins. By cleaving that, you lead to blocking of your acetylcholine release. So understand how these are ingested, spores versus preformed toxin, and understand what they are damaging, your snare protein. Now, what are the symptoms of botulism? Typically, in both botulisms, whether it's infant or adult, you'll have descending, symmetrical, flaccid paralysis. This is very, very similar to GBS, but remember, GBS is ascending. In botulism, you'll have descending symptoms. For an infant, very commonly, this will affect children less than 12 months old, and we look for individuals who have either been playing or eating mud, or individuals who have been given honey recently. Very common symptoms, and the most common, or the first symptom, is going to be constipation. Constipation is generally the first sign due to the ingestion and creation of the toxin in the gut. Remember, these individuals are ingesting these spores, so look for a child with constipation, poor feeding or suck, absent gag perhaps, ptosis. You might see autonomic dysfunction. You might see a wobbly or bobbly head as well. These are all indications of potentially botulism. But again, look for that descending paralysis from the head downwards. In adults, you'll typically see double vision, ptosis again, right? Droopy eyelids, trouble swallowing, trouble speaking. Sometimes if it gets too severe and affects your respiratory muscles, just like GBS, this can lead to shortness of breath. And of course, the autonomic dysfunction, such as dry mouth. For adults, typically, botulism symptoms take place within 36 hours after ingestion. 36 hours. Now, botulism can be remembered by the 4 Ds. Diplopia / ptosis, dysarthria, trouble speaking, dysphagia, trouble eating, and then of course dyspnea. But understand what these symptoms are going to be. Descending symmetrical flaccid paralysis. The diagnosis of botulism is typically clinical, but it is possible to confirm botulism with serum or stool toxins in which you're looking for the botulism toxin. Now, how exactly do we treat botulism? This is going to be dependent on if you're an infant or if you're an adult. For infants, you use human-derived botulism immunoglobulin. For adults, we'll use equine-derived botulism immunoglobulin. This immunoglobulin for adults is used if you're greater than 1 year of age. The equine-derived botulism antitoxin is not used in infants less than 1 year because of the high risk of hypersensitivity reactions, including anaphylaxis as well as serum sickness. The infants have immature immune systems. This makes them more vulnerable to adverse reactions from foreign proteins, such as non-human proteins, such as equine-derived botulism. So understand which immunoglobulin we use per age. Now, There is another subtype of botulism in which it is known as wound botulism. Very simply put, this is typically due to the puncture area being seeded with spores. The symptoms of wound botulism is going to be very, very common and very, very similar to individuals with adult botulism, but typically you'll see signs of infection such as fever, leukocytosis, myalgias, and this is typically seen in IV drug users. The treatment is going to be the exact same. The reason why I include this is because I do not want this to trip you up on your test day. If you see signs of botulism, or what may be botulism, with signs of infection as well, think wound botulism. Now, another type of acute flaccid paralysis is going to be something known as transverse myelitis. Transverse myelitis is an inflammatory condition of the spinal cord that causes damage to myelin and sometimes axons. This often affects both sides of a spinal segment. This immune-mediated process disrupts both motor, sensory, and autonomic pathways. This leads to symptoms like limb weakness, sensory loss, bladder dysfunction, etc. Thus, again, the pathology is going to be an inflammatory condition. Typically damages the myelin. This can either be primary, in which it's typically idiopathic, or it could be secondary, caused by something else, such as an autoimmune condition. The symptoms are typically going to be in someone who's post-infection, such as Campylobacter, here, EBV, AK mono, Zika, Mycoplasma. What does this all sound very familiar as? GBS. So GBS, the same things that can cause GBS can also cause transverse myelitis. So how exactly do we tell these two apart? Well, we're looking for rapidly progressing bilateral, just like GBS, but in this case, this is going to cause a single autonomic function, or a single dermatome is typically affected. This will not be ascending or descending or anything along those lines. This will typically affect the motor, sensory, and autonomic symptoms of a single autonomic function, aka dermatome. This classically causes autonomic issues, which is not a classic finding in GBS. The classic ones will be bladder or bowel dysfunction, or sometimes sexual dysfunction as well. So transverse myelitis is an inflammation of both sides of one horizontal level of the spinal cord. Other symptoms will correspond to the various tracts that are damaged, aka is it L4, is it T2 being affected? Those can depict different types of symptoms. But the big takeaway for symptoms is going to be rapid, bilateral, symmetrical dermatomes are going to be affected here. Look for a single dermatome, single loss of motor and sensory function along one dermatome, as well as autonomic issues such as bladder or bowel dysfunction. This, unlike GBS, will be diagnosed typically with MRI. Now, we actually get the MRI in order to rule out spinal cord compression, which will be covered in future lectures. We may see signs of hypersensitivity here. MRI is necessary to evaluate for structural or compressive pathologies. It is not always indicated in order to diagnose the disease, but we always get it with transverse myelitis in order to look for other things that may be explaining this disease, aka secondary transverse myelitis. Thus, on test day, you definitely want to make sure you order an MRI for transverse myelitis. Now, because of this pathology, the inflammatory pathology that this is, treatment is going to be anti-inflammatory. And there's no better way to treat than high-dose steroids. Definitely understand treatment, that we require an MRI to rule out underlying pathologies, symptom progression, and that is an inflammatory cause. For simplicity purposes, I've made a table here that compares GBS and transverse myelitis. This highlights everything that we've pretty much talked about, these two things, comparing them. Again, the symptoms are very, very important to discern between. GBS, we will get an ascending weakness with areflexia. Transverse myelitis will get a bilateral weakness below the lesion, typically affecting one level of dermatome. We also see some sort of bladder or bowel dysfunction. Now, the last thing that we will discuss is something known as tick-borne paralysis. Tick-borne paralysis is a rare neurotoxic disorder caused by some sort of neurotoxin secreted in the tick's saliva during prolonged feeding, typically greater than 4 to 7 days. Now, unlike infectious or immune-mediated neuropathies, the paralysis is toxin-mediated and not inflammatory demyelinating, as the other diseases have been. Now, the symptoms of tick-borne paralysis will be very much in the history. Look for hikers or outdoorsy individuals or individuals who've recently returned from the Northeast. A multitude of different ticks can cause this. Thus, it is not important to know what ticks can cause this, but just understand that tick-borne paralysis can be caused by a large multitude of different ticks. So look for those classic risk factors. This will typically be rapid within 24 to 36 hours of paralysis. This, just like GBS, will be ascending, symmetrical paralysis with decreased DTRs. You can see how this is exactly like an individual with GBS. These individuals will not have a history of a GI-GU tract infection. These individuals will have a history of recently hiking or returning from northeastern America. This typically also only affects motor. Remember, with GBS, we get motor, reflexes, and you should get some sort of sensory abnormality here or there in GBS. You do not get that in tick-borne. Now, the labs are going to be completely normal because this is not an inflammatory or demyelinating issue. Thus, your LP is going to be normal in comparison to GBS, and your MRI, just like GBS, is going to be normal. How do we diagnose this? Well, we should do a skin examination to look for the tick. And once you see the tick, the treatment here is going to be removal and then supportive. There is no indication for antibiotics, IVIG, steroids, plasmapheresis, etc. in these patients. Thus, how does tick-borne paralysis differentiate from GBS? GBS typically causes symmetric lower extremity weakness over days to weeks with autonomic dysfunction, following some sort of viral illness, GI illness, GU illness. Comparatively, tick-borne paralysis is going to be rapid in onset, typically a day, and you're going to get your plateau of symptoms. It's going to be much, much quicker. Typically, you will not have a GI or a GU or some sort of viral prodrome. You will typically be a hiker. And again, like I did for the other one, here is a table comparing both tick-borne paralysis and Guillain-Barré Syndrome. And that concludes this lecture on acute flaccid paralysis.